Good morning, teacher and class. I will talk about physical therapy management following femoroacetabular impingement correction and acetabular labral repair. My name is Andrea Rivero. Definition: femoroacetabular impingement is a clinical syndrome characterized by abnormal contact between the femur and acetabulum at the end of certain hip movements, especially during flexion, internal and external rotation, and has currently been proposed as an important causal factor of early onset arthritis and hip pain in young adults. The so-called anterior femoroacetabular impact caused by the impact of the face superior, anterosuperior neck with the acetabular rim and that produces the consequent labral compression that to repeat trauma is considered its main cause. Some sport activities can cause for labral injuries if it has to do with the sudden rotation mechanism caused by the practice of this sport. Tennis, golf, and soccer are the ones that can hurt the most labral.
About the femoroacetabular impingement. The femoroacetabular impingement is a relatively recently described term which implies a subtle abnormality in either or both of the proximal femur and the acetabulum, causing interference in the normal hip joint movement. Two basic types of impingement have been described: the pincer type and the cam type. I am sure everyone is familiar with what a pincer is. It is a metal tool with blunt concave jaws that are used for gripping and pulling things. And the cam is a projection on rotating part in machinery designed to make sliding contact with another part while rotating. When both the abnormalities are present simultaneously, it is a mixed lesion. In the pincer mechanism, there is either global overcoverage of the femoral head circumferentially as in coxa profunda or protusio, or local overcoverage of the femoral head by the anterior part of the acetabular rim if the acetabular opening is retroverted. As a consequence, during the joint motion, a bony ridge or osteophytes abuts against the front of the femoral neck. This results in fatiguing and degeneration of the anterior part of the acetabular labrum, along with a small zone of adjacent articular cartilage. There may also be an increased shearing force, mostly in the posterior part of the joint during the medial rotation of the hip. In the cam mechanism, the bony thickening at the femoral head-neck junction causes jamming of the femoral neck against the front of acetabulum and abrasion or delamination of the acetabular cartilage. The acetabular labrum may degenerate later in the course of the disease. The pattern of cartilage damage differs in these two types. In the cam type, the peripheral anterior-superior part of the joint is severely involved, and as the disease progresses, it also involves the central portion of the joint. However, in the pincer pathology, the posterior-inferior joint cartilage may develop damage rather early. This could represent a counter-coalition.
Application in physical therapy. Femoroacetabular impingement occurs frequently in young and athletic patients, a population with high expectation of return to sport and participation in recreational activities. Although initially managed conservatively, many patients eventually require surgery, and many orthopedists choose arthroscopic correction of the bone deformities underlying FAI soft tissue repair. Conservative treatment consists of the restriction of sport activity and thus forces movements of the hip, as well as the usual treatment with analgesic anti-inflammatory drugs. Muscle relaxants, regenerators of articular cartilage, the use of physiotherapeutic methods such as the magnetic field, laser, ultrasound, analgesic current, among others, the intraarticular and extraarticular infiltration of anesthetic steroids. Phase 1, immediate postoperative. Approximate duration 1 to 2 weeks. Phase 1 begins postoperatively with the cause of healing the young and assuming symmetrical range. For the first physical therapy visit on the first postoperative day, the upright stationary bike is started for 20 minutes without resistance. The patient is trained in the use of the brace and continuous passive motion device. Phase 2, intermediate phase. Duration 3 to 4 weeks. Return to full weight bearing. The goal of phase 2 is to ensure that the transition to full progress clearly without the emergence of damaging compensatory stresses. Aquatic therapy can help heal patients of crutches and can be started in the third week, provided the surgical incision are fully healed. Additional studies in the later stage of display include single-leg balancing with non-surgical isometric limb length abduction, eccentric squat exercise, barbell walks, internal oblique balls. Phase 3, leg rehabilitation, resort to pre-injury function. Duration 4 to 6 weeks. Phase 3 is designed to restore the patient to the pre-injury functional level with an emphasis on dynamic exercise in all height movement plus in this phase longest split squats, side steps, and retro walls are instituted to complement the one leg balance squat and shoulder rotation.
For the first exercise, the patient is asked to lean sideways against a wall standing on their operated leg. They bend the non-affected leg up against the wall in front of them. Then they use the non-affected leg to push against the wall while keeping their balance with the muscles of the operated leg. Secondly, we have the forward lunge. The patient is standing straight and then takes a step forwards and bends their knees. Then they return to the starting position and repeat the same procedure with the other leg. Another great exercise are bridges or bottom lifts. The patient lies on their back with the hip and knees bent and a Theraloop around their knees. Then, while keeping tension on the Theraloop, so as to keep the knees apart, they lift the hips and lower the hips again. You may remember this exercise from the Askling hamstring strain protocol. The patient will stand on one leg with the knee slightly flexed. With the arms to the side for balance, perform a dive forward by flexing at the hip joint, keeping the torso straight. The swinging leg can be bent a little bit. Do this exercise on both legs. Again, as a note, the repetitions and sets should be adjusted to the capacity of the individual patient.
Pros and cons. Pros: smaller incision, minimal soft tissue trauma, less post-operative pain, faster healing time, lower infection rates. Cons: infection, thrombophlebitis, artery damage, exercise bleeding, nerve damage, dampness at the incision site.
If you have FAI, your doctor will help you decide if surgery is the best treatment option. If surgery is needed, a procedure using hip arthroscopy may be done to repair FAI. First, space will be created between the ball and socket so that instruments can be inserted. Then, your surgeon will make several small incisions around your hip to insert a video camera and other tools. The cameras will display pictures of your joint on a monitor. Your doctor will thoroughly assess the hip joint and may then remove abnormal bone from the ball and the socket. The cartilage will be repaired with suture anchors. At the end of the procedure, the skin incisions will be closed with stitches or skin tape. After surgery, you will begin physical therapy. Physical therapy is an important part of making a full recovery. Compared to traditional techniques, the advantages of hip arthroscopic surgery may include less pain, an earlier return to activities, including school, sports, and work, a shorter recovery time, and often no overnight hospital stay. At Children's, we perform more pediatric hip surgeries than anywhere else in the country.
Issue split in Ecuador. The overall incidence of FAI diagnosis was 54.4 per 1,000 million person years, and it consistently increased between 2020 to mid 2016. Female patients have a higher incidence that male patients. The utilization of joint preservation operations, including hip arthroscopy, surgical hip dislocation, and antibody periacetabular osteotomy increased over time.
Joint. The head of the femur, the thigh bone, forms the ball. The socket, also known as the acetabulum, is formed by the pelvic bones. The head of the femur and the acetabulum are capped with articular cartilage, which provides a smooth surface that prevents the bones from grinding against one another as the hip moves. Another, more fibrous type of cartilage, called the labrum, forms a rim around the acetabulum. This deepens the socket and contributes to the stability of the joint. Femoroacetabular impingement syndrome, or hip impingement, occurs when excess bone forms at the hip joint. When the extra bone occurs on the head and neck of the femur, it is known as cam impingement. When the extra bone occurs on the edge of the acetabulum, it is known as pincer impingement. Sometimes both cam and pincer lesions are present. Whether the impingement is caused by a cam lesion, pincer lesion, or both, pain begins to occur in the groin and sometimes on the side of the hip along the joint line. Sharp pain may occur in positions that cause the impingement, such as with turning, twisting, or sitting. Over time, damage occurs to the articular cartilage and labrum. As the joint becomes arthritic, pain may become more constant and dull. The torn labrum may catch inside the joint, causing pain, popping, and catching.
Conclusion. Hip pain is a common complaint among athletic individuals. One cause of hip pain in the athletic population is femoroacetabular impingement. FAI is characterized by impingement between the lid of the femur and the acetabulum of the hip joint that to structural abnormalities. Appropriate post-operative rehabilitation is critical for patients success at optimal long-term outcomes. As surgical techniques continue to evolve, rehabilitation protocols must adapt to accommodate change in the surgical procedure and ultimately provide the safe and faster recovery of function for the patient. One such surgical modification has been the incorporation of routine capsular closure as part of the treatment of FAI in the young arthritic patients. Thanks.